Welcome to a new episode of Medicine in 3 minutes. We go straight to the point. The subject is bravely made clear and often illustrated. Let's start. Today's topic is about brain tumor. Regarding brain tumor, there is many classifications. There are primary versus metastatic. There are intraaxial versus extraaxial. There are supratentorial versus infratentorial. And there is an histological classification. Then we will move to clinical feature, frontal lobe, temporal lobe, parietal lobe, and occipital lobe. Then we move to risk factor and associated hereditary syndrome. First one is neurofibromatosis. The second one is tuberous sclerosis. The third one is von Hippel disease. And the fourth one is MEN2A and MEN2B. Then we move to the diagnostic. MRI, CT, CSF cleftside, ring-enhancing lesion, iso-intense meningioma. And then we move to treatment. Surgery, transphenoidal approach, radiotherapy, chemotherapy, and we will conclude with secondary metastatic tumor. Regarding brain tumor, there is 63% are benign and 37% are malignant. 20 to 40% of all other cancers develop as brain metastasis. Let's deal with some histological about neuron and astrocyte glial cell and oligodendrocyte glial cell and ependymal glial cell. From its origin, common progenitor goes to neural progenitor, then to neuron. And neural progenitor can go medulloblastoma, who for glial progenitor give also oligodendrocyte progenitor, which give oligodendrocyte. But it could give oligodendroglioma and glioblastoma. Meningioma 35%, glioblastoma 16%, pituitary adenoma 14%. Intraaxial versus extraaxial. Extraaxial, there is subdural and epidural. Intraaxial include astrocytoma, glioblastoma, and ependydoma. Extraaxial include meningioma, craniopharyngioma, germinoma, and metastasis. Let's review. Classification. Primary versus metastasis, intraaxial versus extraaxial, supratentorial versus infratentorial, and adult versus pediatric. Benign, non-invasive, but can be devastating due to the expansion of mass in fixed volume of skull. Malignant, imply rapid growth, invasiveness, but rarely extracranial metastasis. Most common type, neuroepithelial, glial, astrocytoma. It could be neuronal. It could be polydifferentiated. Others include pineal tumor, ependyma, meningioma, nerve sheath, schwannioma, blood vessel, hemangioblastoma, germ cell, germinoma, pituitary adenoma, craniopharyngioma, and local extension. Clinical feature: headache, matinal headache, headache that come with aging, headache that wake up from sleep, headache that come with Valsalva, and headache with come of visual lesion. From the clinical feature, progressive neurological deficit, usually motor weakness, deficit of cranial nerve, sensory, cognition, personality, headache with intracerebral hyperpression, comes with vomiting, matinal headache, papilledema. Third nerve, strabism. Fourth nerve, rotation internal intowin. V1 around the ocular globe. V2 mandibulary. V6 strabism, and bitemporal hemianopsia for compression of chiasma. Because there is carotid, internal carotid in cavernous sinus, it could be compression. Specific location. The brain is divided into lobe, and each lobe or area has its own function. Frontal lobe, bad reasoning. Frontal lobe, personality change, impaired judgment, defective memory, one-side paralysis, and seizure. Temporal lobe, think of Wernicke, Wernicke aphasia, left hemisphere for right-handed, can speak but cannot understand. Right-handed control writing, language, math, logical, scientific, linear thinking. Less messy, more controllable, predictive. Left-handed control, emotional, creativity, imagination, gestal whole picture, holistic thinking, energizing, risky, require trust. Risk factors include exposure to vinyl chloride, Epstein-Barr virus, and ionizing radiation. Hereditary syndrome associated with neurofibromatosis, tuberous sclerosis, von Hippel-Lindau disease, and exposure to cell phone is being investigated. Von Lindau syndrome, think of Hippel. Autosomal dominant, mutation in suppression gene, short arm chromosome 3, young adult. Unilateral ataxia, headache and dizziness, vision loss, retinal hemangioma, pancreatic adenoma, pheochromocytoma, renal cancer, epipidimal cystoadenoma, hemangioblastoma, vascular tumor, nervous system. Tuberosis, sclerosis, systemic disease, skin, ache leaves hypopigmented purple, brain, cortical tuber subependymal astrocytoma, heart mitral regurgitation, aced retinal hematoma, lung lymphangiome and leiomyomatosis, bone, kidney, angiomyolipoma. Neurofibromatosis, optic tumor glioma, skeletic anomaly, 5 or more café au lait spot, scoliosis, eyelash nodule, and 2 or more neurofibroma. Neurofibromatosis 2, bilateral 8-nerve tumor, hearing loss, schwannoma, nerve compression, headache, facial numbness, poor balance, and tinnitus. Men 2A, pituitary, parathyroid, and pancreas. Men 2B, parathyroid, medullary thyroid, and pheochromocytoma. The diagnosis is a clinical examination, computed tomography or magnetic resonance imaging. The result is then often confirmed by biopsy. Based on the result, tumors are divided into different degrees of severity. CSF clef sign. The CSF clef sign is neuroimaging can be used to distinguish between extraaxial lesion from intraaxial lesion. Use it for the description of meningioma. Magnetic resonance MRI is generally the gold standard used. Benign tumors are hypodense or isodense. Perfusion weight imaging and diffusion weight imaging are used for classical tumor by Gray, technique not used for glioma. The definitive diagnosis is confirmed only by a biopsy or open surgery. A ring enhanced lesion is a radiological sign whereby one has the image there is a lesion with area of hypodensity surrounded by a bring rim from contrast. Typical meningioma appear as dural-based mass, iso-intense, to gray matter and both TN and 2D weighted imaging enhancing, vividly on both MRI and CT. Some of the variants, as mentioned earlier, can however vary dramatically in their imaging appearance. The treatment combines surgery, radiotherapy, and chemotherapy. In case of convulsion, give anticonvulsivant. Dexamethasone and furosemide reduce peritumoral edema. Some tumors grow slowly and only require monitoring. Immunity-based treatments are under study. The results vary greatly depending on the type of tumor and its extent. Transsphenoidal approach for pituitary surgery. Some tumors, although they are benign, can be life-threatening because of their location. Glioblastoma has a poor prognosis. Meningioma has a good prognosis. The 5-year survival rate in the United States is 33%. Secondary or metastatic tumors are about 4 times more common than primary brain tumor. Half of the metastases from lung cancer, primary brain tumor occur in approximately 250,000 people worldwide each year, accounting for less than 2% of cancer. In children under the age of 15, brain tumor come right after acute lymphoblastic leukemia as the most common form of cancer. Thank you for watching this episode of Medicine in 3 minutes. Make sure to push the button like and subscribe. Your comments are very welcome. Thank you.